This is Dr. Hessel recording the presentation on arterial blood pressure monitoring part 1 for Monday, September 16th. I'm going to talk about non-invasive monitoring, the location to which arterial pressure monitoring should be referenced, invasive measurement of arterial pressure, and electronic pressure monitoring. The complete PowerPoint presentation, including supplemental slides and study questions, are posted on Canvas. Reading is in Miller's textbook, Barish and Miller and Prados. I strongly recommend the section in Miller, which is much superior, in my opinion, to the chapter in Barish. I also could refer you to this article on arterial waveform analysis that appeared in ANA a couple of years ago. We do hemodynamic monitoring to detect problems, to evaluate causes of problems, to monitor effectiveness of intervention, and to obtain prognostic information. As far as monitoring our systemic arterial pressure, it's of interest that Harvey Cushing, neurosurgeon, a pioneering neurosurgeon at Johns Hopkins Hospital, was the person who introduced arterial pressure monitoring to anesthesia. He visited Italy after he finished his training and encountered Riva Rocci's Sphygmomanometer, which he brought back to the United States. He and his colleague, Dr. Cerebral, recommended that this become part of standard monitoring in anesthesia. But at that time, the faculty at Harvard felt that it was premature to adopt such a standard. This is a picture of Riva Rocci's Sphygmomanometer, which Dr. Cerebral transported back to the United States. So why are we interested in arterial pressure monitoring? To get a general opinion of the well-being of the patient. It's of prognostic significance. It helps to detect adverse events. It's obviously a key determinant of tissue perfusion. We use it to calculate other parameters like systemic vascular resistance and cerebral perfusion pressure, and to derive other parameters. One of the more important aspects is the reference location of arterial pressure. Because of the effects of gravity, the pressure within columns of fluid, whether it be blood inside the arterial or venous vascular tree or saline inside pressure monitoring systems, varies with vertical elevation. When the patient is level and the transducer is at the same level as the patient, this makes no difference. However, when the patient is not level, such as when the back is elevated, or when the transducer is at a different vertical location than the patient, then discrepancies occur. When a patient is in some position other than level, the arterial pressure will vary in various parts of the body due to gravity. And the change is about 0.7 of a millimeter per every centimeter difference in height. Therefore, if you measure the pressure in the arm or in the leg with a non-invasive device, you will get a different reading than you might have in the brain. Conversely, if you measure pressure with an arterial line, the transducer should be placed at the head level. This shows the significance of the back elevated. If you measure the pressure at heart level or the phlebostatic axis or the upper arm, the pressure will be approximately 15 to 20 millimeters higher than the pressure in the head. The same gravitational effects apply to hydraulic pressure transducer systems. If the transducer is below the level of the body, it will read false high, and conversely, if the transducer is above the level of the body, it will read false low. Therefore, the transducer should be leveled at the position of the body or the organ of interest. This is particularly of concern in regards to perfusion of the brain and calculating cerebral perfusion pressure. As you recall, cerebral perfusion pressure is the difference between the arterial pressure entering the brain and the intracranial pressure. Both pressures need to be referenced to the same level, and therefore the transducers should be at the head level. If the head is elevated above the heart, the arterial pressure in the head will be lower than that at the heart level. And if you don't adjust for this, you will get a false high calculated cerebral perfusion pressure. This error is adjusted by either placing the transducer at head level or correcting the pressure measured at heart level to the estimated pressure at the head level by subtracting 7/10 times the elevation in centimeters. Again, to emphasize the significance of this, if one intracranial pressure is 20 millimeters of mercury and the pressure in the heart is 80 millimeters, you would calculate a cerebral perfusion pressure of 60. However, the actual arterial pressure in the head is closer to about 40. Is closer to 60 millimeters instead of 80 millimeters, and therefore the cerebral perfusion pressure is only 40. Quite a difference in terms of cerebral perfusion. Now, many authorities emphasize this point, that when calculating cerebral perfusion, both transducers should be measured at the same level, namely at the heart level. This has been reinforced by numerous articles. While most experts agree that arterial pressure should be referenced to the head level, there are a few who don't, and unfortunately, often this practice is not followed. This was a recently published survey of the practice of where arterial pressure is referenced in neurocritical care. In this survey, first they reviewed the literature on cerebral perfusion pressure and were able to analyze 16 articles, and they found that in only about 40% did they use reference at the head level. They then surveyed members of the Neurocritical Care Society and again found that only about 40% referenced arterial pressure to the head level, whereas 60% referenced it to the heart level. Other surveys have found similar results. A survey of ICUs in Australia and New Zealand found that only about 15% referenced the pressure to the head, and a survey in the United Kingdom found that only about 20% referenced the cerebral perfusion pressure to the head level. So we have a ways to go. Let me turn now to non-invasive measurement of arterial pressure. This was originally done by Riva Rocci by putting a cuff around the arm, which I've shown a picture of, and then palpating the arterial pulse at the wrist and identifying systolic pressure as that at which the pulse recurred. A few years later, the Russian physician Korotkov described the use of a blood pressure cuff and auscultation over the brachial artery using the so-called Korotkov sounds as the way of identifying systolic and diastolic. What we use most commonly nowadays in the operating room is oscillometry, putting a blood pressure cuff and connecting it to a machine. This technique was first described nearly 100 years ago, but did not come into common practice until the mid-80s with the appearance of the so-called Dynamap machine. What oscillometry does is to simultaneously apply pressure to the cuff while monitoring oscillations within the cuff. A microprocessor analyzes the oscillation in the cuff produced by the pulsating artery. Pressure is applied to the cuff starting above systolic pressure and then is gradually lowered. As you can see from this block diagram, the cord coming from the cuff goes into the machine where it's divided. One supplies the pressure in the cuff, and the other monitors the pressure inside the cuff. And this graph here illustrates what is seen. The upper graph shows the pressure applied to the cuff. So initially pressure is applied to above what it anticipates systolic pressure is, and then the pressure is gradually lowered. At the same time, the machine is analyzing the oscillations in the cuff. When the oscillations start to increase is what it calls systolic. And when the oscillations stop decreasing, it calls diastolic. But when oscillations are maximal, that is what it determines to be mean arterial pressure. The mean arterial pressure is determined directly by the oscillometer. It is not calculated, and it is the point of maximum oscillation. This is the most accurate parameter that oscillometry provides. Both systolic pressure and diastolic pressure are estimated based on various proprietary algorithms and therefore are not as accurate as the mean arterial pressure. Systolic pressure is more accurate than diastolic, but neither are as accurate as mean pressure. In order for oscillometry to be accurate, the cuff size must be appropriate, and this refers to the width of the cuff compared with the circumference of the arm. If the cuff is too narrow, it will give a false high reading, and if it's too wide, it will give a false low reading. It's desirable to have the bladder directly over the artery so you get good oscillations. It should be well fitting, and in obese patients, often putting it on the forearm gives a better fit than the upper arm. And finally, because many of our patients have vascular disease and have subclavian stenosis, you should place it on the arm with the highest pressure. This was a study done more than 20 years ago in which they compared the variability in pressure in the arms in patients coming for vascular surgery. Notice that in as many as 10% of patients, systolic pressure varied by more than 45 millimeters, and in 5% of patients, mean pressure varied by more than 20. These are obviously clinically significant differences, and is why one should check pressure in both arms before selecting the arm in which to measure blood pressure. Now, studies have evaluated the accuracy of oscillometry in critically ill patients, and with variable results. Let us then turn to invasive monitoring of arterial pressure. The reason we do might want to use invasive arterial lines is to get more accurate blood pressure, especially in obese patients, low flow states, patients receiving drugs, patients during cardiopulmonary bypass and during CPR. It provides second-to-second monitoring, which can be important during induction in fragile patients when administering vasoactive drugs, when surgical manipulations are liable to cause marked changes in blood pressure, like aortic clamping or unclamping or rapid exsanguination, and during episodes of arrhythmias. It's also helpful in analyzing arrhythmias. Of course, it gives access to arterial blood gases and to any kind of blood test, commonly glucose and hematocrit and electrolytes. And finally, as we'll mention later, arterial lines are now used to help assess stroke volume and fluid responsiveness. Some of the indications for arterial lines are patients in whom you cannot measure the blood pressure readily by non-invasive means, when you anticipate rapid changes in blood pressure, when patients are receiving IV vasoactive infusions, when prompt control of blood pressure is important, such as patients who are prone to ischemia, who have vascular aneurysms, when you're concerned with elevated intracranial pressure or inducing hypotension, patients with severe pulmonary dysfunction, and for certain surgical procedures, particularly vascular, cardiac, thoracic, intracranial, trauma, solid organ transplants, bronchoscopy and thoracoscopy, and airway surgery. Now, we speak of arterial pressure as though it's a single number, but in fact there are many different components to it, and each provides different information. The systolic pressure reflects the myocardial effect and systolic wall tension and myocardial oxygen needs. It influences left ventricular afterload and hence LV output and ejection fraction. It reflects the vigor of LV function and influences the stress on arterial blood vessels, which is particularly important in patients who have aneurysms and who have new arterial suture lines. The disadvantage of systolic pressure is that it can be easily distorted, giving false representations, especially during invasive monitoring and to a lesser degree during non-invasive monitoring. I mentioned earlier that the systolic pressure is not as accurate from the oscillometer as is the mean pressure. Diastolic pressure determines coronary perfusion. It determines the pressure that the LV must develop before it can begin to eject. And finally, a low diastolic pressure may suggest a low systemic vascular resistance or a high runoff, such as aortic regurgitation or AV fistula. Or finally, it could be a clue that the zero on the arterial line has changed. It's my opinion that the mean arterial pressure is the one that we should be most interested in. It is hemodynamically the most important, since it reflects the pressure that is actually perfusing the vascular beds. It's also used to calculate cerebral perfusion pressure and systemic vascular resistance. And most importantly, it is the one that is least distorted by both transducer systems and by oscillometry measurements. In the past, there has been interest in looking at the upslope of the arterial pressure waveform, so-called dP/dt, since it could reflect the destructive effects of arterial pressure and reflect the contractility of the left ventricle. However, by the time the pulse reaches the periphery, it is markedly distorted. So using the peripheral dP/dt is not very valuable. Arterial pulse pressure, as you know, is the difference between the systolic pressure and the diastolic pressure. and importantly, it reflects stroke volume. Recently, and we'll briefly mention this now and in more detail in tomorrow's lecture, the area under the systolic pulse curve has been used to measure stroke volume non-invasively, and also the variability of the pulse pressure is being used to assess fluid responsiveness. As I mentioned, analysis of the contour or area of the systolic waveform is now being used to estimate stroke volume and thus calculate cardiac output, both requiring calibration and more recently not requiring calibration. And we will go into this in much more detail tomorrow. This review article from a couple of years ago in Anesthesia and Analgesia discussed in more detail the use of arterial waveform analysis. The effects of respiration, especially positive pressure ventilation on arterial pressure, is referred to as respiratory variation and is commonly now being used to assess volume status. As illustrated in this slow amplified tracing, normally with respiration the blood pressure goes up and down, and the amount of variability has found to be related to intravascular volume and volume responsiveness, which again we'll discuss in much more detail tomorrow. There are also some unusual arterial waveforms of interest to us. One is the fact that the arterial waveform changes as it travels down the arterial tree. The upper tracing is from the proximal aorta and the lower tracing from the distal femoral artery. And what you see is the pulse pressure widens, the upstroke is delayed, there's a delay and slurring of the dicrotic notch, there's a more prominent diastolic wave, and mean arterial pressure declines ever so slightly. There's a phenomenon called pulsus alternans. This is when every other pulse is weaker or stronger, and it is said to be an early sign of ventricular dysfunction. Another phenomenon is Pulsus Paradoxicus, described by Richard Lauer and Adolf Kussmaul, which reflects the effect of respiration on which reflects the fact that with respirations the blood pressure goes up and down, and when exaggerated it can be a sign of constrictive pericarditis, and nowadays is used as a sign of hypovolemia. This shows the arterial trace in a patient with an intra-aortic balloon pump pumping every other beat, and you see the pump markedly raises diastolic pressure and conversely decreases systolic pressure. During cardiopulmonary bypass, most pumps are non-pulsatile, and so you don't see a typical systolic pressure waveform, but only very low amplitude oscillations. Now, like everything in medicine, everything we do is a two-edged sword with benefits and complications. And I always like to emphasize complications because they help you decide the risk-benefit of a procedure. It tells you what you should do to try to minimize them, what to look for, and instructs you to be prepared to treat these complications if they occur. The first set of complications are false data, and this can be because the transducer system is miscalibrated or it's in the wrong position, as we illustrated earlier. And there's a phenomenon called ringing and damping. And I will discuss both of these at the end of this seminar. You can also get false information due to vasodilation. This is very common early after cardiopulmonary bypass. And with proximal occlusive disease, which we already mentioned. During harvesting of internal mammary artery, there's often compression of the arm on that side. And of course, if the surgeon happens to clamp the subclavian artery, you will lose the pressure in the radial artery distal to that subclavian. Other complications are listed on this slide. Thrombosis of the cannulated artery depends on many factors and has been found to occur in between 10 and 30% of patients after radial artery cannulation. This is usually only temporary, but it's of significance when we go to recannulate it. Ischemia is a constant concern and is partly related to thrombosis of the vessel and poor collateral flow. We'll come back to infection in a moment. Cerebral embolism is possible when you vigorously flush an arterial line. Even when the line is in the radial artery, it's been demonstrated that rapid flushing, 10 cc's in 1 or 2 seconds, will actually go all the way up to the subclavian and even innominate artery, and therefore potentially into the brain. Finally, there's always a risk of someone injecting a drug into an arterial line. I know I have done it, and I suspect it occurs much more common than we know about. And I suspect that this may be the cause of a number of the cases of so-called ischemia, which is because some kind of sclerotic drug was injected into the radial artery. As far as infections, there is confusion in the minds of many clinicians and even textbooks about the risk of infection associated with arterial lines. And many consider the risk to be low, especially compared with central venous lines. However, there are now numerous studies that have demonstrated that the risk of colonization and of bloodstream infections associated with arterial lines is comparable to that associated with central lines when placed in comparably ill patients for similar lengths of time. This is one of the most recent studies from France, in which they studied more than 2,000 cases. And they found that the risk of colonization and catheter-related infection did not differ between arterial catheters and central venous catheters. This shows for the arterial catheter and the central venous catheter the incidence of colonization. You see it was nearly the same, 8% with arterial lines, about 10% with central lines, and the incidence of catheter-related bloodstream infections or major catheter-related infections were no different between arterial catheters and central venous catheters. This shows the incidence of colonization over time in the arterial line. What these investigators also demonstrated that just like their benefit with central lines, the use of antimicrobial sponges, such as a bile patch, markedly reduce the risk of colonization and major bloodstream infections in arterial lines, reducing these risks to 1/3 of the risk when they weren't used. And the same was found for both radial artery lines and femoral artery lines. Similar results have been found in many other studies with a colonization rate of somewhere around 5% and a bloodstream infection rate of somewhere around 0.3%. All studies have demonstrated that the rate of colonization increases with time. Another important observation is that the incidence of catheter-related infections is about 3 times higher with femoral lines than with radial lines. And importantly, the organisms found with arterial femoral line infections were different than those with radial. With radial, about 90% were due to gram-positive bacteria, whereas with femorals, about 40% were due to gram-negative bacteria and 15% were due to yeast. So why are arterial lines at risk of infection? One is, I believe, there's less care in aseptic technique. Secondly, there's often a lot of movement at the wrist. And finally, arterial lines are frequently accessed for blood specimens. So why have they been thought to not be associated with infections? It's because most of them are placed in low-risk patients and removed in 24 to 48 hours. And in these situations, the risk of colonization is very low. In summary, arterial lines are associated with a similar rate of catheter-related infections as central lines. And therefore, we should use the same strict aseptic techniques during their placement and monitoring that we do for central lines. A wide prep, a wide drape, wearing cap, mask, and sterile gloves, and I believe a sterile gown, and placing a biopatch around it, checking it daily, and remove it when you suspect the patient has a bloodstream infection, and covering with appropriate antibiotics, especially noting the difference if it's a femoral line. Although most people don't recommend using sterile gowns for art lines, even though it's standard of care for central lines, I still recommend because, number one, it heightens the awareness of the risk of an infection and the importance of strict aseptic technique, and it minimizes the risk of contaminating the field with the unsterile arm or contaminating the guide wire with the unsterile arm. Now, a few things about placement of arterial lines. I want to talk first about choosing a site, and then the side and the time of placement, say a few words about Allen tests, and then some specifics about inserting these lines. There are many different sites. The most common is the radial because of its ease, safety, and access. The limitations is if it's not patent or the patient has poor collateral flow. The ulnar is actually larger than the radial, but because we don't commonly use it, people are unfamiliar with it. Furthermore, if the radial is absent or you've tried the radial and you've lost the pulse, I personally am hesitant to then use the ulnar, even though I know of no data showing the danger of it. The brachial is somewhat easier than the radial, being a larger vessel. The concern has been that there's poor collateral around the radial, but in fact, large series have found a very low incidence of ischemic damage. But certainly whenever you place a brachial, you need to be extremely careful in your monitoring, and if any signs of limb ischemia develops, to have a vascular surgeon take care of it. The axillary has the advantage in that it has better collateral flow around it. On the other hand, it's closer to the central aorta, and therefore, I believe, at greater risk of causing cerebral embolization. In my hands, it's a little more difficult. The femoral is a great place because the vessel is often large, and it can be easy, at least in a skinny person. And it is a central line, and therefore gives a much more reliable arterial pressure. Unfortunately, many of our patients have peripheral vascular disease, which makes this an unreliable line. And as I've already mentioned, it is associated with a higher infection rate. So I think it's a good line to use for a few days, but then you should consider changing it out if they need more prolonged monitoring. Pedal pulses are inviting. I find them a little more difficult to place and not to last as long. And finally, there's the superficial temporal. We have an occasional patient who has no good arteries available in the extremities, and the superficial temporal may be the only place you can get a line. This works very well in the anesthetized, quiet patient. However, they're not very stable once they're awake. And furthermore, since it's a branch of the carotid artery, there's extreme risk of cerebral embolization if one isn't careful. Now, it's important to consider the side in some of our surgical patients. Remember that when surgeons are working near the left subclavian artery, such as for coarctation surgery, surgery for patent ductus arteriosus, and surgery on the descending thoracic aorta, often they will clamp the left subclavian, and therefore you certainly don't want your arterial line in the left side. For ascending aortic surgery, many recommend placing it on the left side, but I favor placing it on both sides so that you know if there is interruption of the innominate as well as the subclavian. In general, for cardiopulmonary bypass, I personally prefer using the right because it tells you something about the pressure in one of the cerebral vessels, namely the right carotid artery. If there is anticipated cross-clamping of the descending aorta, such that you may want to know the pressure distal to the cross-clamp, you may wish to put a line in the femoral artery, and if so, you should use the right, because these patients will be in the right lateral decubitus, and if the surgeon has to use the femoral artery, that the surgeon will want to have access to the left femoral artery, and you don't want to have your line in that artery. As far as timing, in regards to placement of a PA catheter, if you plan to place both an artery line and a pulmonary artery catheter, I recommend that you place the arterial line first so you have it to help detect and manage any complications that might develop during central vascular access. As far as relation to induction, I personally favor placing it prior to induction, since time of induction is the time of hemodynamic instability, and furthermore, it's available once the operation begins. The argument against is that it's uncomfortable to the patient. I think if the patient's adequately sedated and you do a good job of local anesthesia, an art line should be no more painful than starting a peripheral IV. Once you've numbed the skin, there should be no further pain. If the patient exhibits pain while you're placing an art line, it's because you've done an inadequate job of anesthesia. The Allen's test is designed to assess collateral flow around the radial artery. Generally, since we commonly place radial arteries, it's to determine if the ulnar artery is adequately perfusing the hand. If there's poor collateral, there's a theoretic risk, increased risk of ischemia of the hand. Now, some have argued against using it because there are false positives and false negatives. But this is true of everything we do. And I think most authorities recommend that if you have time to do it, and if you have an alternative site available, then you ought to do the test. Why run the risk of ischemic damage? Now, like everything, it's important that it be done properly. And on this slide, I've described how I recommend doing it. Raising the arm, having the patient make a fist with the arm inside, then occluding both arteries, lowering the arm and opening the hand, leaving the arteries occluded for 5 to 10 seconds to induce significant ischemia, and then releasing the ulnar artery and noting the time it takes to reperfuse all parts of the hand, especially the thumb. Normally, this occurs in a few seconds. Anything over 5 seconds is abnormal, and in my opinion, if it's longer than 15 seconds, I am hesitant to use that radial artery. If a patient is not cooperative, you could use a Doppler of the digital arteries, or more conveniently, place a pulse oximeter on the thumb to determine whether there's a flow into the thumb. Now, many of our patients have had previous arterial lines in the radial artery, and as I indicated, a fair percent of these will cause occlusion of the proximal radial artery. Even if the proximal radial artery is occluded, they can still have a palpable pulse at the wrist, which is being perfused by the collaterals from the ulnar artery. If you try to put an arc line in these arteries, you get a flashback, but when you try to advance the catheter, you don't get any flow because the radial artery is occluded proximally. Therefore, I recommend that in all of these patients that you do what I call the reverse Allen's. In other words, checking to see if the radial artery is perfusing the hand. So you occlude both vessels, lower the hand, release the radial, and see if it is perfusing the hand. A word about setting up the transducer. We're all spoiled because our technicians often do this, but remember, you are ultimately responsible. And the most important thing is that the irrigation system and all of the catheters be totally free of air. I have occasionally encountered when the system hasn't been washed out, and this could lead to disaster. I also think it's important to make sure there's no air left in the irrigation bag. Secondly, the system needs to be zeroed. So you open it to air and then press the 0 button on the monitor, which tells it that is what we call 0. Now, it doesn't make any difference where the transducer is when you zero it. The pressure in the basement is the same as the pressure on the 16th floor. However, nurses have been taught to always re-zero it every time the transducer is moved. It's not necessary, but don't argue with them. The third most important thing is positioning the transducer at the proper level. For systemic arterial pressure, this should be, in my opinion, at the level of the head. When the patient's supine, of course, you can use the phlebistostatic axis or any other place on the body since the pressures are the same. But when the head is elevated, then it's critical that the transducer be at the head level. For filling pressures, for pulmonary artery pressures, the convention is to level it at the mid-axillary line, the so-called phlebistostatic axis. The modern machines are very accurate in terms of the gain, and I have rarely, if ever, encountered a transducer that gives you false gain. Usually it either works or it doesn't work at all. However, if you want to check it, you can do it gravimetrically, and I've demonstrated how to do this. You connect a length of tubing to the stopcock. You fill that tubing with fluid, and then turn the stopcock so that that fluid level is being impressed onto the transducer. If the level is 40 centimeters up in the air, then it should read about 30 millimeters of mercury. Everyone has their own technique for placing radial artery lines, and on these slides I have described my technique. There is nothing particularly better or worse than any other technique. This is not evidence-based, but it's how I do it. I will emphasize that I think it's important to fix the arm and to use strict aseptic technique. I like to go not right at the wrist, but a little bit proximal to the wrist, so that when the patient flexes their wrist, they don't bend the catheter. It's important to, I think, place adequate local, and I make a skin incision with an 18-gauge blunt needle to facilitate passing the catheter through the skin. Now, I think it's important not to hyperextend the wrist, and this was reinforced by this article published a couple of years ago that demonstrated that, in fact, when the wrist is extended more than 60 degrees, that the AP diameter of the radial artery is narrowed. I think it's important to suture the catheter to the skin. That's what the nurses expect. The Aero system comes with this fixation device which you strap onto the groove and then suture the fixation device. The problem with this is the catheter can easily fall out of this groove, and so I strongly oppose using that fixation device. And instead, I recommend suturing it. And again, this is the idiosyncratic method that I use. I put the suture transversely in line with the groove underneath the catheter, and then bring the suture back underneath the catheter and suture the suture, tie the suture to the skin very snugly, and then bring the line back under the hub and tie it tightly into the hub. And I think this assures better fixation and lack of motion of the catheter than other ways of fixating it, and also assures proper alignment of the catheter into the artery. Finally, I put a biopatch on as I illustrated here. For brachials, I favor use of the 20 centimeter single lumen pediatric IJ. This is about 4 inches long. And for femorals, I use the single lumen 16 gauge adult IJ. But these are simply my preferences. As far as ultrasound guidance, as you know, it is now a standard to use ultrasound for placement of internal jugular lines, and this document from the American Society of Echocardiography and the Society of Cardiovascular Surgeons address the use of ultrasound for placement of arterial lines, and they do not recommend its routine use. However, as they point out, there are good data indicating that use of ultrasound does improve the rate of success on the first attempt. And this is a meta-analysis of these 4 studies, and you see 3 out of the 4 studies showed a significant decrease or significant increase in success on the first attempt if you use ultrasound. My personal opinion is, for what it's worth, that use of ultrasound can be very helpful for femoral and brachial and axillary arteries, and for finding the radial artery proximal to the wrist, but I don't think it needs to be done routinely for radial arteries, but maybe it should be. If so, I think people would then quickly lose their skills at placing it without ultrasound. Finally, I want to talk about electronic pressure monitoring. Nowadays, all of our monitoring of both arterial pressures and even central venous pressures and pulmonary artery pressures are done with transducer systems. These are electronic hydraulic systems, and there are a number of potential problems. One is improper zeroing and setting of the gain, which I've talked about. Second, and very important, is improper positioning, which I've mentioned on several occasions. And the other two are the problem of ringing and damping. Ringing refers to an exaggerated response to phasic variation in pressure, and it's seen with both systemic arterial and pulmonary artery pressure monitoring. And it results in a noisy trace with extra spikes. And the significance is that it results in a false elevation of systolic pressure and a false depression of diastolic pressure. But the good news is it does not affect mean arterial pressure. So let's talk a little bit about ringing. This is what it looks like, and you see all of these extra spikes on the trace, and this spike here represents a false elevation of the systolic pressure, and these negative spikes are a false depression of the or elevation of the diastolic depression of the diastolic pressure. Here is an illustration of a fairly good trace without ringing, and conversely a trace with ringing, with elevation of the systolic pressure and depression of the diastolic pressure, and gives you a clue to some of the causes of this, which are mainly long extensions and multiple transducers. Ringing is due to resonance, which refers to a positive response to the input signal. It occurs when the frequency domain of the biologic signal, in other words, the arterial pulse wave coming out of the patient, approaches or overlaps the natural frequency of the transducer system, plus the fact that the system is underdamped. Now, the transducer systems themselves, the transducer normally has a very high natural frequency of over 50 hertz. Unfortunately, this is markedly degraded by long tubing, stopcocks, and micro air. The biologic signal coming out of the patient increases when you have tachycardia, hypertension, and a dynamic cardiac contraction. And thus it's seen in stress patients who have a good heart. So many of our trauma and neurosurgical patients exhibit this increase in the biologic signal and a proneness to this ringing. This is the formula for the natural frequency of the transducer system and points out those factors that influence the natural frequency, including the diameter of the tubing, the length of the tubing, the density of the fluid, and the viscosity of the fluid. Thus, things that will cause the natural frequency of the transducer system to deteriorate is long, narrow tubing and stopcocks, compliance due to micro air, and, as I've already mentioned, long tubing. The other requirement is that you have an underdamped system. So how do you recognize ringing? Mainly by the appearance of the waveform, as we've mentioned before. Another clue is when the arterial transducer systolic pressure is substantially higher than that the cuff is reading. This can be checked by measuring what is called the return of flow pressure. You place a blood pressure cuff on the arm with the radial artery line. you initiate cycling. As the pressure is applied to the cuff above the systolic pressure, the wave will disappear. As the pressure in the cuff gradually declines automatically, you should note when the cuff pressure, when the arterial waveform starts to reappear. This reflects the return of flow pressure. If the arterial systolic pressure is 10 to 20 millimeters above the return of flow pressure, then you should suspect the presence of ringing.